everybody will be starting soon.
Alrighty, let's get started, guys. Good afternoon, everyone. I'm Sohaib Galani. For the new fellows who don't know me yet, we'll be talking about inhaler management in stable COPD, something that we run into every day up on case 17. So we'll start with the clinical case. The initials don't have anything to do with me, okay? 56-year-old guy comes in, current smoker, known COPD, basically tells you he can't breathe well. And all my friends who are the same age, hint, hint, keep this in mind, walk faster than me. His HPI, essentially increased dyspnea exertion, no steroids, no increased cough, sputum, no COVID symptoms. And his kids told him that he cannot be his own lung doctor because apparently he's a pulmonologist as well. He is a current smoker, 2 packs per day from the last 40 years. Physical exam-wise, relatively unremarkable, maybe some scattered wheezing. His spirometry does show signs of obstruction and no diffusion limitations. And he tells you, hey man, I graduated in 95 and I stopped reading journals at that point. So what are the current trends for treatment of COPD? Because my albuterol does not work. So you being the astute fellow, leave the room, grab your report or copy of the Global Initiative for Chronic Obstructive Lung Diseases, or the GOLD 2020 report. Now, just to give you a little background about GOLD itself, the first report was issued in 2001. The committee had started in 98. It's a combination of the National Heart and Lung and Blood Institute, the National Institutes of Health, or the NIH, and the WHO as well. And since 2001, they've been publishing an annual, basically a literature review and a clinical guidance on what the most appropriate management strategies are. And we will discuss the slight nuances in the 2020 report. So the one thing that they did mention that was slightly new this year was really the definition of what constitutes COPD. Persistent respiratory symptoms with an airflow limitation. And we'll talk about what they define airflow limitation as. Obviously, the airflow limitation is measured by spirometry itself. They did make a side note about not using the term emphysema in a clinical context, as that is a radiological and pathological diagnosis. And they did make a special comment about the entity of COPD asthma overlap and how that they should now be treated as 2 separate entities which may coexist rather than a continuum. And they only made that one statement here. Will someone raise their hand? What does that mean? How do I do that? Click that. I don't know what to do. Okay. So we won't really get into the asthma COPD dilemma, as that is a whole talk on its own. But I just wanted to make you guys aware that they did make that specific comment in the 2020. Let's see. Oh. Okay. I need a more technologically savvy person than myself.
What do they say? It's not.
They're saying my slides aren't moving. Is it sharing the long screen, or
Is it working now?
okay, perfect. All right, COPD is the 4th leading cause of death in the world. approximately 3 million people have died from complications of COPD, and it's projected to rise pretty substantially throughout our decades of practice. The one slight caveat is the rise in COPD is not only in smokers. It is 11% across the world do have COPD from environmental exposures rather than tobacco smoking itself. So keep that in mind as well. Okay, so talking about the gold ABCD paradigm itself. Now, this paradigm was first introduced in 2011. In 2017 was the major shift from using the spirometric data as part of the assessment. Now, the FEV1 is still part of the assessment tool, but you do not use the number for management decisions, if that makes sense. Now, as I mentioned, we will talk about how they're defining obstruction. And they are using the value of 0.7 for your ratio. And if you guys remember, 2 weeks ago, we did talk a little bit about PFTs and how there is not a consensus on using a fixed integer versus a lower limit of normal ratio to define obstruction. If we do use a fixed ratio, we do run into trouble where a greater diagnosis of elderly people may be made of obstruction who may actually be normal, and a lesser diagnosis in younger people. Just remember here, we do use a lower limit of normal to define our obstruction. However, the GOLD report does use the fixed integer. Now, they did keep the assessment of airflow limitation as part of their initial assessment to really guide advanced therapeutics, eligibility for transplantation, and other interventional pulmonary type of situations. So the actual ABCD group is really defined by two things. One is your exacerbation history, and two is a measurement of your symptoms. Now, the way the GOLD ABCD paradigm is set up is they try to objectify the symptoms that the patient's feeling using one of two methods. Now, the MMRC, it's initially a bit of a historical aspect to COPD. The initial prevailing thought was that dyspnea or breathlessness is a predominant feature of COPD, and that's where the MMRC came about from. Now, if you remember, our gentleman had told you something important in his HPI, and he mentioned that he walks slower than his other buddies. So keep that in mind. That may come up. Now, when we do take a look at the COPD literature, they do use something called the SGRQ, or the St. George's Respiratory Questionnaire. It is a fairly comprehensive questionnaire. It's been extremely well validated. And just to give you a ballpark number, the numbers you get from it are 0 to 100. And they've shown that the cutoff of 25 and below is uncommon for people who do have COPD. So that's the kind of cutoff that they use. And a decrease by 4 in this questionnaire is considered a clinically significant improvement in symptoms. So keep that number in mind as well, please. Unfortunately, it does take 15 to 30 minutes each time to complete it, so it's not clinically practical. So they did develop a CAT assessment, which is much quicker and has been validated, and the number of 10 on a CAT corresponds to about 25 on your SGRQ. Now, in terms of the SGRQ itself, it has been shown that the higher your symptoms are, the higher risk of exacerbations, higher risk of hospital admissions, and higher risk of death as well. And this was on initial diagnosis of COPD. Now, the CAT score has not been validated in this aspect quite yet, so we're not sure if we're able to extrapolate that same kind of projective data from a CAT score, but it has been validated for the SGRQ, and that's why a majority of the COPD literature takes into account the SGRQ to evaluate for quality of life issues. Now, where the ABCD paradigm helps us is really for initial pharmacological management of COPD. So anyone care to venture where our gentleman falls? So he told you a little bit of information. He told you he's not had any steroids, he's not had any wheezing or productive cough, so I don't think he's had any exacerbations. So he'd fall under Group B. So he told you, so his MMRC is approximately 2. We were just lazy and we did not do a CAT score, so we'll call it Group B. Now, we have a choice between a LAMA or a LAMA. Okay, so that's how do we decide? So of course he is a pulmonologist, so he's like, well, since you told me we have 2 options, which one's better? For my flow rates, for my quality of life, and for my mortality? Again, the fellow's panic-stricken and runs out of the room. This is turning into quite a visit. So you decide to do a quick literature review up on K17. Before we go into this, there are some commonalities amongst most of the COPD trials that are out there. One, keep in mind that a lot of these are industry-related trials. 2, keep in mind that since they are industry-related trials, a lot of them have significantly sicker population than what may normally be seen in a primary care type of setting. And that plays a role into the generalizability of any of the data that we have. Some common endpoints for the majority of COPD trials: one is flow, or FEV1, quality of life measured by the SGRQ, like we talked about. And remember that a change or a decrease in 4 is considered clinically relevant. Exacerbations and hospitalizations and all-cause mortality and cardiovascular mortality in specific as well. So taking a look at the FEV1, initially, as I mentioned, it was thought that to go back a little bit here, the FEV1 on a population level has been shown to correlate well with mortality and hospitalization risk. However, on a patient or individual level, that is not so. The FEV1 does not correlate well with symptoms, does not correlate well with mortality in an individual patient, and symptoms as well. So now taking a look at some of the data here, what this is showing you is FEV1 decline over time. Now, as you can see, and this is multiple trials over a couple decades here, and the trials are using the multiple combinations of medications that we have currently. So this one's showing you a LAMA versus placebo. Here we have triple therapy versus a LAMA-LABA. Here we have a LABA-ICS and a ICS as well, and same thing over here. Now, the overall trend that you can see is that none of these combinations prevent a decline in the FEV1 over time. There is an initial increase in the first year to 2 years or so, and after that, we do have a precipitous decline in the FEV1, and this is true for all medications that we have. Now, in terms of the SGRQ scores, taking a look at them overall, remember we said that a change or a decrease by 4 is clinically relevant. So here we do see when we initially start inhaler therapy, we do have a decrease in those scores to maybe around 3 or 4. And this is, again, taking a look at the various different combinations of medications that we have. However, as time progresses, the quality of life does get back or closer back to baseline. Now, the cardiovascular mortality itself, when the long-acting beta agonists came around, there was concern that there may be associated with an increased cardiovascular risk given that there may be some systemic uptake of the inhaler medications themselves. Fortunately, in any of the trials, there has not been an increase in specifically cardiovascular mortality, and they actually tried to answer the specific question in patients who do have a higher cardiac risk in the SUMMIT trial, and there was no increased risk in cardiovascular mortality or arrhythmias as well. And this is a nice meta-analysis of the various combinations of medications that are on the market. And this was in 2015, so up to 2015, showing us that there is no increased risk of cardiovascular mortality. However, there has been no decrease in all-cause mortality either, despite any of the different combinations of medications that we have so far. And this encompasses your LAMA, your ICS, and the various combinations of them. Now, we were trying to answer the question on which inhaler regimen to use for our gentleman. So we decided that he falls in the group B, and that we will be choosing between a LABA or a LAMA. So one of the first trials to really take a peek at what a LAMA does was the Uplift trial in 2008. They took a look at 6,000 patients, tiotropium versus placebo. I'd like you to pay attention to the demographics of the patients in these various trials. As you'll see, this does limit the generalizability of most of these trials to people who have mild COPD. And it also obviously limits the meta-analyses that come from this data as well. Their primary outcome was a rate of decline of FEV1. And as I mentioned, these outcomes, both primary and secondary outcomes really revolve around these four, essentially, for most of the trials. So as expected, our SGRQ data did show an initial decrease with a subsequent increase. And we did not have any statistically significant all-cause mortality decrease. However, there was a slight decrease in our COPD exacerbation rates, which were, let's see, and on average, we had 14% less exacerbations, and it did increase the time for your first exacerbation as well. And again, this is comparing tiotropium to placebo. Now, there is pretty robust data for LABAs as well. So the Cochrane review published in 2013, that included 26 randomized controlled trials, 15,000 patients. They were comparing the two LABAs that are on the market versus placebo at that time. Taking a look at the SGRQ, or the quality of life data, it did favor the LABA over the placebo. However, the overall change was -2, so not clinically relevant. And if we take a look at the risk of exacerbation, it did favor the LABA side as well. And again, this is something that we intuitively know now. So that still doesn't really answer the question on should we choose a LABA versus a LAMA. Both of them have been shown in their respective studies to decrease exacerbation risk, increase slightly the quality of life, no mortality benefit. So in actually this year, there was a head-to-head meta-analysis that was published to help us decide on this topic. So 19 randomized controlled trials, around close to 30,000 patients, and LAMA and LABA were compared head-to-head. So in this meta-analysis, we did have LAMA was favored in terms of reducing your exacerbation risk over LABAs. And our quality of life scores were not statistically significant, and the average decline in both groups was close to 4. So what this data shows us here is that the reduction or the improvement in quality of life is roughly equivalent in both groups. However, the exacerbation risk or a number of exacerbations is decreased using a LAMA. They did mention the FEV change, as we've previously discussed, that no inhaler regimen has really been shown to sustain a improvement in your FEV1. So what would you guys like to do for this guy, based off of the data that we have? Maybe go with a LAMA? Sure. So you put him on LAMA therapy. Finally, your clinic has now resolved, and he will come back in 3 months. It was a very long clinic session, Dr. Tatum. So, so now I know you guys were busy over the springtime. However, there was slightly busy. But if you were still paying attention to pulmonary medicine, the ATS did come out with pharmacological management guidelines. This was in February 2020. And the way they designed it was really 6 PICO questions that are clinically relevant. And the first PICO question that they brought up was in patients with COPD who do have dyspnea, so our patient falls under this category. Is LABA-LAMA combination therapy more effective than both of them combined? And they based the majority of, so this was based upon the meta-analysis that their group did as well, comparing head-to-head dual LABA-LAMA therapy versus either or monotherapy. There was a significant reduction in the exacerbation risk. Same is true for an improvement in quality of life. However, the change was only 0.13, so not terribly clinically relevant. Now, this has become a little bit of a controversy because the ATS guidelines are specifying that we should not be using monotherapy in patients. We should be using dual LABA-LAMA therapy as our initial inhaler regimen. I'd like to take a poll of everyone here, including our visitors online. Is this something that we have been, or is anyone been doing this clinically? And any thoughts behind why or why not?
I don't know. I think anecdotally, I probably see an increase of maybe, prescriptions for an oral or CO pill. I think anecdotally, but I don't know that it's been widespread practice. I know personally I haven't, but I know I haven't.
That would be a bad day in the ID office. Some of the controversy surrounding this data, as I mentioned, the underlying studies typically tend to use a lot sicker population. So that's something to definitely keep in mind on, is this generalizable or not to the patient that you're treating? Daniel, you had something? No. Okay, so he comes in for a 3-month follow-up, said he was doing great on his LAMA. However, he went out to a party that he was not supposed to, caught some virus, we're not going to name anything, and he had a COPD exacerbation and was in the hospital for it. Okay. So now the ABCD paradigm is really designed to help you choose an initial pharmacological management. Now, if you do have worsenings on the management that you chose, they did develop a cleaner version of an algorithm on which one to follow. So ignore the blue one for now. We'll get back to that one. So we're in the exacerbation algorithm right now. So the way to use this tool is to figure out which of these combinations that your patient's currently on. So our patient is on a LAMA. And now we can branch into either a LABA-LAMA, or the combination, or a LABA-ICS. Now, they do make a slight caveat that in order to make this decision, they would base it off of high eosinophilia or significant or low eosinophilia and a lot of exacerbation history. Okay, so something to keep in mind here. So again, frantically run out of the room because, so our patient's a pulmonologist, by the way, was a current smoker. So, so the TORCH trial wanted to take a look at the effectiveness of a LAMA ICS versus the individual components. And again, we mentioned the outcomes are pretty similar to the other COPD trials. Now, take a look again at the patient population that they studied. Average age of 65, 76% were males, and pretty significant COPD or flow limitations. Now, when they did take a look at the all-cause mortality, unfortunately, there was no difference. However, there was so it was not statistically significant. However, there was a 17% decrease in the mortality in this study, despite it not meeting statistical significance. There has been some controversy regarding this trial as well. One thought was that they did have a lot of sicker patients in their patient population, which may be accounting for the decrease in mortality, or the decrease in mortality. In terms of the exacerbation rates themselves, we did have a decrease as expected compared to placebo, and a significantly decreased exacerbation rate in the combination versus the monotherapy. And again, the same very similar pattern to the other inhaler regimen that we have in terms of their quality of life. Now, whenever we start talking about inhaled corticosteroids, the adverse effect of pneumonia comes into play. Now, in the TORCH study that we just took a quick look at, there was a significantly higher proportion of patients who did have pneumonia. And this has been validated in other studies as well. Taking a look at a meta-analysis on the two ICS that we have on the market, fluticasone and budesonide, the fluticasone tends to cause more pneumonia. So just something to keep in mind. Now, the one interesting caveat is that there's no increased risk of mortality. So we're not sure if these pneumonias are, well, we know that they're not causing an increase in mortality. However, they're still causing morbidity. Now, head-to-head trials of LAMA versus LAMA ICS. Again, fairly large trial. The one negative about this trial was that they used different components for their inhalers, so the data is a little difficult to interpret from that aspect. Now, initially, the study was actually designed as a non-inferiority study to study LAMA ICS versus the LAMA. However, the study actually met superiority criteria. And again, you have to keep in mind that the individual components are different in both the groups. And we did show that they did decrease the exacerbation risks. So now the Cochrane Review actually published a dual combination therapy, LAMA ICS review here, which was statistically significant just slightly. They did favor more the LAMA over the LAMA ICS for a reduction in exacerbation risks. Okay. So now we are sort of back to our patient here. So he was on a LAMA, he had an exacerbation. We don't really know, and it was a at-home, not hospitalized exacerbation. We don't really know what his eosinophils are, but what would you like to do at this point? Shraddha, what would you do? Okay, sure, we can try LAMA. So that's what we do, and we'll see him back in 3 months. There's some entrepreneurs out there. So 3-month follow-up, he's been maintained on LAMA therapy. Said COPD was doing fine. And he mentions that you will be a good pulmonary doc. So kudos, guys. However, he did go on a boating trip with a friend who was coughing all day, and he thinks he caught some virus again, and he had a COPD exacerbation for which he was in the hospital. So now again, this time, yes, and a non-smoking pulmonologist. So now he is on a LAMA, and he's had an exacerbation on that. Now, for the gold, so for people who remember the 2018 gold guidelines, they had recommended for this kind of patient to be on triple therapy right away. However, there has been a change since 2019, and that change continues into 2020 on what criteria is needed to fall in that category here. So to go from a LAMA to a triple therapy type of deal, they're considering patients with high eosinophilia or eosinophil counts, essentially. So we'll take a look at some of the data behind that. There's been multiple studies published more recently regarding the triple therapies. This is a meta-analysis published this year, actually, taking a look at the triple therapy versus LAMA therapy, or continued LAMA therapy. And no surprise there, we do have a significant decrease in the amount of acute exacerbations in the triple therapy group. And they did do a subgroup analysis on the frequency of the exacerbations that people are having. Unfortunately, the data was a little limited on the low exacerbations, so I wouldn't really pay too much attention to this group right here. But in terms of people who've had multiple exacerbations, the triple therapy, the reduction in acute exacerbation on the triple therapy side is favored by triple therapy. Now, in terms of pneumonia, again, whenever we talk about ICS, the risk of pneumonia comes into play as well, and this was validated in the triple therapy groups as well for an increased risk of pneumonia. So what about these eosinophils? What's the deal? Yeah, I don't really know what that means, the early eosinophils. I put that in this morning, so. Now, there was an interesting, so this has not been studied head-to-head. This data is extrapolated from the various COPD studies that have been published so far, so the data is a little sketchy. However, this very nicely done meta-analysis took a look at the available data that we did have. And what they found was, in terms of the exacerbation rate itself, people who had a higher eosinophil count tended to have more exacerbations. Now, this graph is showing you treatment with an ICS. And what they noticed was having the addition of the ICS in patients who have elevated eosinophils, the effect size is much greater. So the reduction of exacerbations is higher when you have higher eosinophil counts on an ICS. And taking a look at some of the other data that was published alongside with this, they did have a significantly improved and sustained quality of life. And again, this was more pronounced in patients who had high eosinophil counts, and there was slight increase in the flow rates as well for those people. So something to consider. Yes?
Did the authors kind of give a rationale for why they think that's happening?
So their thought was that there may be a more of a inflammatory component that was being treated by the ICS that was accounting for the decreased exacerbation risks.
I think it was because of the Wilson trial, I think, in 2014, where they tried to take off ICS, so they weaned them off, and the ones that that didn't do so well on the weaning are the ones that had high eosinophils, whether again COPD or inflammatory.
Or maybe an overlap syndrome.
Right.
So the GOLD report came out with factors to consider when to start ICS treatment. They said a history of exacerbations and eosinophil counts. They would strongly support that. Against the use, obviously, repeated pneumonia events, since the risk of pneumonia is higher, and having a low eosinophil count. Anywhere in the middle is physician discretion. Now, let's talk a little bit about this blue graph here before we go into the ATS guidelines. The blue graph, and we'll talk about the exacerbation or the algorithm as well. Now, this is taking into account no exacerbations on your current inhaler regimen and only or a lack of symptomatic control. So what the GOLD guidelines recommend is either you're on a bronchodilator. If you have persistent symptoms, you go to dual therapy, so dual bronchodilators. And if we run into trouble with that, they don't recommend initiating ICS at the time. However, maybe switching around the combination of LAMA that you are using. Now, this is taking into account that we do not have exacerbations. Does that make sense on what they're recommending at least? Now, if someone is on triple therapy or on a LAMA ICS, they do recommend taking off or withdrawing the ICS if there has been no exacerbations in the last year. Pretty similar for the exacerbation side. Now, as I mentioned, the ATS did publish the guidelines in 2020 or February 2020. Some of the other PICO questions that they talked about is the triple therapy compared to dual bronchodilator therapy more effective? And what they mentioned, and this is in congruence with the GOLD guidelines, is that for patients who have had one or more exacerbation, that they do recommend triple therapy over dual bronchodilator therapy. And we did talk about the ICS withdrawal in patients who have not had an exacerbation in 1 year, and they are in congruence with the GOLD guidelines at that point as well. Now, in the topic of the blood eosinophilia did come into play as well for the ATS guidelines. They did not make a recommendation for or against, as this topic has not been extensively studied so far. The data is it's not we have not had head-to-head trials of this yet. Now, the one thing to consider is that we don't really have head-to-head data between the various formulations of medications that we use. Our assumption is that these are class effects for medications. However, taking a look at this one really nicely done meta-analysis, they used the various formulations that were on the market at that time. And you can see that there are differences in the amount of exacerbation risk that various formulations do reduce. So something to just keep in mind. Unfortunately, we don't have head-to-head trials, as the majority of the data does come from industry studies for these medications. So for our gentleman, he was stepped up to triple therapy, given the multiple exacerbations and his high eosinophil count. And we plan to remove his ICS if he has not had an exacerbation in a year's time. I have never seen lungs in the sky, but who knows? All right, some take-home points for you. I know that was a lot of dry data. So the first take-home point, there was no sustained improvement in lung flows over time for any of these inhaler regimens. However, there is an increase over placebo use. There is no all-cause mortality benefit for any of the medications that we use. No increased risk in cardiovascular mortality. And as I just mentioned, there's no head-to-head trial for the different formulations, so we assume that there is class effect for these medications. Combination therapies do reduce exacerbations more than monotherapies. ICS is associated with pneumonia. and considered adding on an ICS in higher exacerbations and higher eosinophil counts. Some homework for you guys. Take a look at the ATS 2020 guidelines. The Goal 2020 report is actually really nicely written. There's a lot of non-pharmacological management strategies built into the document, so I'd suggest taking a look at that. Okay, now we have 2 questions for you, okay? Hopefully you guys are paying attention. First question, and these are from the SEEK questions, I didn't make these up. So you're asked to consult with and assess a patient with COPD, diagnosed 6 years ago. Her FEV1 is 58, ratio is 0.48. She has to stop walking after 150 meters, CAT score is 17, has had 1 exacerbation. So they're asking you to make her goal classification. And since you guys have been so nice to me, I gave you a little hint. So remember, the grading is based upon their post-bronchodilator flows. So hers is 58, so she'll fall under goal 2, right? And remember that the group category is based off of exacerbation history and their symptoms. Here we have a CAT score of 17 and 1 acute exacerbation. So group B. So that would be B, correct? Okay. And the real test is not going to give you a cheat sheet. All right, question 2. Stable, symptomatic individual with mild or moderate COPD. What is the effect of daily maintenance inhaled LAMA bronchodilator therapy? So there is no benefit in lung function or acute exacerbation history or frequency. Increased adverse effects, improved mortality, improved lung function, and reduced acute exacerbation frequency. And so, hey, please talking about COPD. What do you guys think? So let's go one by one. No benefit in lung function or acute exacerbation history or exacerbation frequency. That's not true, right? Because the acute exacerbation history does get reduced. Increased adverse effects for LAMA. LAMAs are generally well tolerated. Typically, no systemic uptake causing your side effects there. Improved mortality? No. Improved post-bronchodilator lung function? That is true, but there's no sustained, so it's improved based off from your baseline. However, overall, there's a decline over time, okay? And reduced acute exacerbation frequency. And E is probably true as well. Special shout out to Dr. Tatum. And thanks everyone who works up on K17 to help our patients breathe a little bit better.
Let's see if there is.
Any questions, comments, please? Insurance issues for LAMA is still an issue. Obviously, there's a whole component of what's appropriate for our patients, taking into account the financial difficulties as well. Any comments, questions, guys? Anything from our virtual audience?
Someone raised
Raise
his
their
hand.
What do you do with that? Like
I
click
don't
on it?
know.
What are you supposed to do?
I'm not sure. I think.
Oh.
It should show up in here.
Allowed to talk?
Oh.
Oh, was that a mistake?
Oh, can you do that? Is there a way to unmute everybody?
Down after Dr. Continue to read them.
Yeah.
One more.
Just to unmute. Maybe we can promote the panels. I thought there's a way to mute everybody at once.
Clearly, I can spend much time on Zoom.
I guess. All right.
I guess we're done.
All right. I guess we're done.